I'm Catherine Cook from Massey University, and I have a shared interest in intimacy and sexuality in aged care with our presenter Alison Rahn. And most of us would associate our intimate and sexual moments of our lives with the need for privacy, but this is a much contested area in aged care, and so we're most fortunate to have you, Alison, to come and speak to us. Alison has been practicing as a sex therapist for a number of years in Australia. She also has 20 years experience as an architect and is currently undertaking a doctorate at the University of New England, and she'll be speaking to us about her research involving baby boomers and their expectations, and also about people who are currently in aged care. And her research has already attracted much media attention and gained her a research position at the Australian Catholic University in Sydney. So welcome, Alison.
Thanks, Catherine, for that kind introduction. And I want to personally thank Blair Stewart and the Office of the Privacy Commissioner for inviting me to come and speak here today. It came as a huge surprise, and I was very, very happy to participate. I'm going to commence my presentation with a short video. And the video is a news story from Canada. It's less than 2 minutes long, it's not long, but it encapsulates a lot of the issues that would save me a lot of words explaining. While you're watching the video, what I would like you to do is imagine yourselves in this situation. Put yourself in this couple's shoes and watch the video from that perspective.
It's a picture seen around the world. A couple in their 80s, married for 62 years, crying because they're separated.
He's very sad because he knows his time is limited with his wife.
Their granddaughter, Ashley Bartik, shared the photo on Facebook days ago. More than 3,000 people worldwide paid attention. So did the national and international media.
They are just overwhelmed with emotion when they see the photo. I think it just shows it's not a Canadian issue, it's an international issue.
The attention has catapulted the plight of Ashley's grandparents, Wolf and Anita Gottschalk, into the spotlight. The couple is separated due to the healthcare system and their different needs. Right now, there is no bed at Anita's facility for Wolf, who requires a high level of care. He has dementia and has just been diagnosed with cancer. Their Surrey care facilities are about 40 minutes apart.
Please help me get my husband. I want to be with him.
The family is fighting to reunite the pair. They've been waiting to hear from Fraser Health. Shortly after their story caught the attention of the world, officials contacted them this afternoon, saying their situation is top priority.
It's been a very difficult situation for the family, but also for us. It's not a situation that we like to see. So we are waiting for them to be able to move them into a residential care spot at their preferred site. Unfortunately, we have to wait for a spot to come up.
Ashley is hoping their story helps other families in the same situation.
What we want to shine the light on is the lack of subsidized beds in this province.
But until there is a subsidized bed for Wolf, he and Anita will long for each other.
Well, one of them will die of a broken heart, guaranteed. I don't believe that's just in fairy tales. I believe that happens in real life.
Jennifer Palmer, Global News.
Thank you. This situation that you've just seen, which happens to come from Canada, is extremely common throughout the world. It's certainly extremely common in Australia. And it's something that's not discussed and not really thought about, except when it comes to this personal level of experience. Can you hear me better now? Okay. Now, can you imagine how difficult it would be for this particular couple to spend private time together when they live in separate aged care facilities? You saw the scene of them tearily saying goodbye to each other after one of their infrequent visits. And that was done in a public space in the in the public living area of the aged care facility. There's nowhere private for them to have those moments together. And these are things that we take for granted. One of the things that I will be doing today is not just presenting my research, but I hope to challenge you, to ask you to think differently, to put yourselves in these people's situations. Because until, as researchers and clinicians and healthcare experts, we start doing that, it's not going to change. We need to be having these conversations. Oh, by the way, the conclusion to that story was that the couple was eventually reunited because of all the media publicity. They spent 6 weeks together in their new facility before the husband died. So the urgency of trying to get them together was not just for the media publicity, it was a reality for that couple. And for many couples, they don't have the benefit of being reunited in that manner. So just imagine that. When I commenced my PhD in 2014, I thought what I was setting out to do was to research the sexual needs of couples in residential aged care, and in particular in the baby boomer cohort, because I anticipated that the sex, drugs and rock and roll generation might have slightly different attitudes to those who are in aged care currently. More importantly, what I've discovered on that 3-year journey so far is that there's something far more fundamental to couples than their sexuality, and that is respect. Something so simple, respect. As a culture, and I'm talking about Australia, but I suspect I'm referring to all Western cultures, we don't respect ageing, we don't respect older people, and we don't respect their relationships. And this type of thinking permeates every level of government, every level of policy and planning. It permeates building design, it permeates staff training, and it permeates attitudes. And this affects couples in a layered way. For most of us in this room, getting old will be inevitable. It's not anything we can do about it. And you may not know, but in New Zealand, if you live to be beyond age 65, you have a 28% chance of dying at home. So just imagine all of you in this room, about 1 in 4 of you will have the privilege of dying in your own home. The rest of you will die in a residential aged care facility or in a hospital. In Australia, the statistics are even more dire. 1 in 7 Australians dies at home. And we have a much, much higher rate of institutionalised death. In fact, we're the 2nd highest in the world. So I want you to think about what kind of aged care experience would you like to have? Most people, when they consider this, say, I'm never going to go into aged care. However, most people in aged care don't choose to be there. It happens because of a health crisis. It could be a fall, it could be dementia, it could be a chronic illness. But most people don't choose to be in residential aged care. They end up there because they need it. And none of us knows which of us is going to need it. If we don't start discussing this and researching it and coming up with best practice to approach it, nothing is going to change. And the experiences that are happening now are just going to repeat themselves into the future. So can I just have a show of hands? How many of you in this room have a spouse or partner? And keep your hands up if you took a vow that said something like, we will remain together until aged care do us part. No, I didn't think so. And yet this is what happens for many married and de facto couples. So in Australia, we have approximately 51,000 aged care residents who are married or in de facto relationships. No government agency keeps any data on how many of those couples enter aged care together and how many become separated in the process. It's not worth recording, it seems. It's not important. Nobody asks that question in the record keeping. They ask, are you married or are you in a relationship? But they don't ask, are you entering with your partner? Where is your partner living? That type of thing. So there is no record of how many of these 51,000 people are together with their partner in a residential aged care facility, possibly in separate aged care facilities, or one is in aged care and one remains in the family home. So in this presentation, I plan to provide an overview of the issue of couples' privacy in residential aged care. I'll share some of the results of my research, and I'll leave you with 7 dimensions of privacy to consider in the aged care setting. So one of my research questions is, what are the privacy needs of aged care residents? And from the literature review, I discovered that there are many privacy breaches that happen for residents in aged care. And these range from doors being compulsorily left open. So residents' doors can never be shut in some facilities. In fact, some facilities have no doors at all, I've heard. There is constant surveillance. Now that might be in the form of staff constantly entering rooms to check that nobody's had a fall, or surveillance cameras in corridors. In America, there's a move to have surveillance cameras in the residents' rooms, and there's a growing demand for that to happen in Australia as well. So surveillance is a big issue. Separation is another issue that causes privacy problems. Now, the separation is not easy to encapsulate, but it covers a number of areas. So I've already discussed couples being separated by only one entering the facility. But there's also different forms of separation that happen. Staff intervene to keep partners apart in some facilities to prevent sexual contact. Some partners are separated by being put in separate beds, separate rooms, or separate wings of a facility because it suits the providers to handle it that way. Other issues relate to staff attitudes towards residents and things such as gossip and labelling, such as dirty old man. That type of thinking is very, very damaging to residents, but it's often taken for granted in some residential aged care facilities. There's very little private space, often none, in an aged care facility. Where do you put your personal belongings? Can you stop anyone entering the room? Is your room your own personal domain? And one of the overarching problems is the contested nature of the residents' rooms. For residents, it's their personal space, but for staff, it's their workplace. And the workplace seems to take precedence over personal space. So, because I had baby boomers as my end target group, this PhD study's been broken up into 3 phases. So it's a mixed methods study. The first phase consisted of key informant interviews. There were 29 people invited to speak, and each of those interviews took at least an hour, and they were semi-structured interviews, so people could discuss whatever they liked, but there were certain things that I wanted to cover in the interview. Those interviewees ranged from directors of aged care facilities, upper level managers, care managers, nurses in training and carers. And they also included educators and trainers both at tertiary and vocational level. And they included allied health professionals who work in aged care facilities, one of which included a sexual health physician. I even interviewed a sex worker who works in aged care facilities. So there was quite a broad range of expertise that I was drawing on, and also academics and researchers, obviously. Now, the information gathered from those initial interviews was then used as background for the next two stages. And one of the questions that arose as a result of the interviews was, well, what protections are there for couples in residential aged care? Are there any at all? And if there are, why are they not working? So that was where phase 2 came from. So that was basically a review of all legislation since actually 1954 that related to aged care residents and couples in that context. What I discovered was nothing happened between 1954 and 1974, so I reviewed documents from 1974 onwards. So that included all the parliamentary debates before each bill was introduced into the House, and the debates that continued until legislation was passed, and associated media coverage of those debates. It was quite colourful, some of it. And that will be the area that I'm mostly speaking about today, because that material has been published and phases 1 and 3 are still being analysed. Having done stages 1 and 2, I was then well informed to go to baby boomers and ask them to participate in an anonymous online survey. It was both qualitative and quantitative in nature, and participants volunteered to participate. What I didn't anticipate was that about a third of them were workers in aged care facilities, so they had a particular interest in this area. And the other 2/3 of them all had had a parent at some point or another in aged care facilities. So they were a very well-informed group of participants. So this is a quote from phase 1. Where in a nursing home can you lie down on the bed next to each other and just cuddle? Let alone any form of sexual activity. Someone's always around. Not all the rooms have doors. So what this told me is that the literature review, the lack of privacy that was revealed in the literature review was being validated in current time. So it's still an issue even now, and this quote is from 2015. In the phase 2, the political and legislation review that I did, I was using search terms to help me narrow down the field. So I was looking for the term couples, married, aged care, nursing homes, sex, sexual needs, sexual expression. Believe me, that narrowed the field a great deal. And this is what I came up with. So these are various documents that have been produced, the first being in 1954, right up until 2015. So in those 60 years, we've had 6 documents that have looked at reforming the protection of couples in residential aged care. The first one being the most unique and momentous. So in 1954, the Menzies government in Australia instituted the Aged Persons Homes Act. Why this is important is that up until this point in time, we had basically the English poorhouse model of aged care in Australia. It had evolved into convalescent homes and geriatric hospitals, but there was nothing about those facilities that you would call a home or home-like. They were institutions and they were very medicalised. So in 1954, the government passed this legislation that allowed funding to go to churches and charitable organisations to build something more home-like for older people. And it targeted married couples. And in fact, the protection of married couples was written into this Act. And it's the only piece of legislation in Australia that protects aged couples. It's now no longer current. It was, I think about 5 years ago, it ceased to be. Okay, as I said, nothing happened for the next 20 years. Okay. The Whitlam government came along and did a Royal Commission into Human Relationships. The only Royal Commission of its kind in Australia, and I wouldn't be surprised if it's the only one in the world, ever. And one of the findings in that study was that aged care residents who were married had no protection of their married status. It was often impossible for partners to sleep overnight with their partner. And there was also no provision of sexual health services or information for older people in residential aged care. Moving on to 1987. So in the late 80s, worldwide, but particularly in English-speaking countries, there was a growing move to standardise aged care within countries, to have standard levels of care accepted by all concerned. And in exchange, providers would receive government funding. So Australia was no exception. And then in 1990, again, worldwide, there was a debate about the rights of aged care residents. And Australia instituted a Charter of Residents' Rights, which outlines quite a detailed list of rights. The next piece of legislation that I thought was relevant was the Human Rights Sexual Conduct Act of 1994. This is the only human rights legislation that Australia has, and it basically says that all Australians have the right to conduct their sexual relationship in privacy without interference, no matter what your sexual orientation is. And then more recently in 2015, we had various amendments to the Aged Care Act that removed any remaining discrimination within the Act. Up until then, churches and charitable organisations had the right to discriminate against residents on the basis of their sexual orientation or sexuality. So in 2015, last year, that changed. So this is the 1954 Act. So basically, residents were to live in conditions approaching normal domestic life with proper regard to the companionship of husband and wife. Unfortunately, those well-meaning sentiments have severely eroded over the last 60 years. In 1990, when the residents' rights were being debated, there was a proposal to insert this phrase into the residents' rights, that residents have the right to be treated with dignity and respect, including the right to have religious, cultural, sexual and emotional needs treated with respect. Can you imagine the response? The Catholic Church was outraged. This is a quote from Mother Mary John from Little Sisters of the Poor. It was quoted in the Sydney Morning Herald. We wouldn't be able to implement our home's philosophy. The draft agreement aims to give residents the right to indulge in adultery, fornication and sodomy in our homes. So the language, the colourful language that's being used really incited divided loyalties. Yes, the expression on your face says it all. And so powerful were these arguments, and so heavily did the churches lobby politicians that the politicians caved and removed any reference to sexual or emotional needs from the residents' rights. Our current version of the Charter of Residents' Rights is more general in nature, so it preserves personal, civil, legal and consumer rights, dignity and respect, personal privacy. It's supposed to provide a safe, secure, home-like environment. It allows residents to select and maintain personal relationships and control their daily life. However, rarely does this come to pass, even though this is enshrined in legislation. Why is this so? Because it's too general. This is entirely open to individual interpretation. When looking at the issue of sexual privacy, this is the Human Rights Sexual Conduct Act that I referred to. So this is the wording: sexual conduct involving only consenting adults acting in private is not to be subject to arbitrary interference with privacy. It applies to old people as well as young. We currently have accreditation standards in Australia, and funding is linked to accreditation, so providers must prove that they are following the guidelines. But again, look at this. It says, each care recipient's right to privacy, dignity and confidentiality is recognised and respected. Well, what does that mean? How do you measure it? How do you prove that you're doing that? It's entirely arbitrary and open to subjective interpretation. And this is one of the points that was raised by one of my interviewees, who is quoted below. To get any real shift in the industry, it has to be legislated. We need explicit statements and standards. At the moment, there's no measure. It's very subjective. So how do you define privacy? Well, I particularly like this quote from Simon Bronnett, who was discussing the European Convention on Human Rights. And he describes privacy as something more than prevention of intrusion. He said it goes beyond the negative conception of privacy as a freedom from unwarranted intrusion to include the positive right to establish, develop and fulfill one's own emotional needs. So you think about how you spend your time in private. What do you gain by being in private? This is what he's talking about. Preserving the sanctity of that space. Now, there's a couple of points I want to make about couples and privacy and sexual relationships. The literature clearly shows that there is a lack of privacy for couples in residential aged care, and particularly in relation to their sexual relationships. The second point is that healthy couple relationships have been found to promote better health and longevity and reduce depression, for instance. And thirdly, that privacy in itself can serve healthy functions. So the literature shows that it preserves personal autonomy. What you do in your own private time is your business and no one else's. It provides an opportunity for emotional release, an opportunity for self-reflection, and it's a space for protected communication. And most of our privacy legislation is to do with communication and data storage rather than those other functions of privacy. So I would invite you to think of privacy a little differently. These categories were gathered from literature in health and aged care. So the 7 categories of privacy have been described by various authors. Social privacy refers to interacting socially with someone of your choosing and not interacting with those not of your choosing. So if you think about an aged care facility, often people are seated at the dinner table next to someone they would rather not be with. That's social privacy. Informational or data privacy is what we've mostly been discussing today, so record keeping and sharing of records. But it also includes things like gossip, passing on personal information through personal gossip. Now that is something that is quite common in aged care. Communications privacy refers to having visual and auditory privacy to conduct conversations on the telephone, to search the internet, to send text messages, to Skype, that type of thing. Auditory privacy is protection of not only preventing being overheard, but also preventing overhearing other people. So it's a two-way thing, not wanting to hear other things and not wanting to be overheard. Visual privacy is the same, except in the visual domain. So not wanting to see things you don't want to see, but also not wanting to be watched when you don't want to be watched. Territorial privacy refers to space and storage issues for residential aged residents. You know, for instance, their cupboards can be accessed by any staff member at any time in many facilities. Their rooms are entered often with people not knocking or asking permission to enter, etc. And then bodily privacy refers to not only medical interventions, but things like washing and bathing and toileting, and whether or not that's done in a respectful way, whether consent is given to it happening, and whether there are other people looking on. So recommendations arising. This is in its early stages, but I would suggest there needs to be a feedback loop where there is a constant innovation and improvement in the aged care industry. And it needs to start with consulting with residents themselves. Research that identifies what residents' privacy needs are, and then incorporating those into the legislation. Following that, we need the legislation to be translated into standards. The built environments need to be designed with couples in mind and also privacy in mind. You know, we're not just talking about visual privacy, we're talking about those other levels of privacy. Perhaps it's not such a bad thing to have a lock on the door, for instance. And it might serve other functions like preventing sexual assaults. Then, you know, there's a filtering up process that needs to happen. Policies and practices need to be consistent with providing privacy to couples. Staff need to be trained as to what couples' needs are, what privacy means, how you respect somebody's privacy. When residents are admitted into a facility, they need to be asked, well, what are your privacy needs? What do you consider important? How would you like to be respected? And then resident feedback needs to be sought. Well, how well are you doing? Are we giving you what you need? What else do you need? And then a feedback loop such as that. And I'm going to leave it there for the purposes of brevity and open the floor to questions.